Good morning, everyone, and welcome. I am so honored to be at the Liver meeting in person. So excited to see all of your faces. A little humbled that there might need to be an overflow room for a talk by a patient at the Liver meeting on diversity, equity, and inclusion. I think that speaks a lot for hepatology, a specialty to which I am so grateful 28 years post-liver transplant. When I think about diversity, equity, and inclusion, I think that my life is a testament and a testimony to when we get it all right, when we invite in people who may look differently, may speak differently, may embody leadership in a different form that we're used to, and make sure that they have everything that they need to be successful. So that's my testimony, but my purpose is to make sure that every patient has the best chance at that same outcome. So, I'm Donna Cryer. I'm the founder and CEO of the Global Liver Institute, and I am so proud of my team who is here, and I encourage all of you to meet us. We're usually wearing burgundy of some sort, the color of liver health, and I could not be more grateful to have a team of people who have agreed to align with my vision and dedicate their careers and their talents to making the world better and more receptive to liver patients from all stripes and sources. I don't have any disclosures. I do have a bias towards action. I have a bias towards getting stuff done. So those are my biases. So the journey I'm going to take you on this morning for the next 30 minutes or so, and I want to leave real time for conversations because I know that the wisdom in this room does not primarily reside on this stage, but in those seats. So I want to make sure that I have the advantage of hearing from you and knowing what's on your minds. I think that's what makes GLI impactful. We want to listen, we want to learn, we want to constantly evolve to do better. So we can't talk about equity without defining it. So often, I believe, conversations in this space go awry because we're not even talking about the same thing. So I want to start off by defining equity. I then want to move into talking about the various types of inequities that we see in this space so that we can be more precise about the solutions that we are creating. We often talk about stigma. It's this sort of nebulous thing that some people think are just, well, feelings. What do feelings matter in all of this? I want to talk about how stigma harms. Access is a word that we use frequently. But what is meaningful access? It is a much more complex concept and a much more complex pathway to get right. There are policy opportunities. We're here in Washington, D.C., my home for 30-some years, and I could not have a talk without spending some time on the policy framework that are necessary to ensure that what we want to put in place in the diversity, equity, and inclusion space actually happen. And finally, I want to give you the GLI vision for equity and examples of the work that we've started to do for our Center for Liver Health Equity, and I'm so excited to see some of our advisors for that center here in the room. And hopefully that is just the start of a conversation that we will have on this area. So defining equity. So it's certainly not just treating everybody the same, just as we wouldn't give them everybody the same dose of medicine, no matter what their weight or no matter what type of disease they have. Often, we would see those first two pictures. You know, let's give some people a boost so that they could see over the proverbial fence, or, you know, in our case, so they can get the medicines that they need or the treatment that they need. I would challenge us to tear down the fence. Why is the fence there in the first place? As we think about this in the context of healthcare, I think we have to ask questions like, why do patients need to go to academic medical centers for clinical trials? Why do 1,000 different things happen? Why does a business model favor procedures over talking to a patient and their family and providing the cognitive services that may figure out really what's wrong and get to the root of the problem? I think too often we worry about the little boxes and we don't think about just removing the fence. So I want to challenge us as we think about equity initiatives as ways that we can take down the entire fence. When we think about types of inequities, because they are myriad and many, there's certainly the inequity between liver conditions and other conditions. One example is simply looking at NIH estimated 2022 funding, $3 billion for HIV versus $644 million. $3 billion for HIV versus $644 million for all forms of hepatitis, despite the prevalence rates of hepatitis being much higher. When we look at the budgets of patient advocacy organizations, the American Heart Association, the American Cancer Society, organizations that do fabulous work, and I've had the benefit of consulting for some of them and talking with many of their leaders even earlier this week. We are a fraction. If you can roll up all of the patient advocacy organizations in the liver space, I don't think we are equal to the CEO salary of the American Heart Association. We have to do better. If we want to have advocacy do all of these things, then we need to invest in advocacy. If we want to have research in liver disease, to be able to solve all these problems and to find treatments for the hundreds of liver diseases that do not have treatments or cures, then we have to invest in it. And we have to invest in it at a level of the prevalence and the impact both on the healthcare system, but on communities and families that liver diseases collectively have, not only on this country, but on all countries. There's certainly the inequities between liver diseases. We are privileged at the Global Liver Institute to convene more than 200 organizations across our Liver Cancer Council, our NASH Council, and our Pediatric and Rare Liver Diseases Council, and they are very different ecosystems when we're talking about cancer, or which has an infrastructure for both advocacy and care that is very mature, although not inclusive of liver cancer until very recently. But NASH we had to build. We built it with Wayne Eskridge, I want to call out here as well. The first brochures, the first patients, the first initiatives were all within just the past 5 years. Think about that. There was no advocacy structure, so there could be no equity structure in NASH until we built it. The beauty, though, and the opportunity, though, if you're going to start a field from scratch, why don't we do it the right way at the beginning? Why don't we invite everyone to the table at the start rather than as an afterthought? And so I am very excited that Our NASH Council from the beginning had the Association of Black Cardiologists and the National Association for Hispanic Health as the first calls, not the last. And I think that needs to be the way forward. Baking in diversity to everything we do, rather than sort of, my team knows I call it tacky, because people just sort of tack it on at the end. Let's not be tacky anymore. Let's include the people and organizations from the beginning. But between liver diseases, there are inequities, and we need to be sensitive to the different structures that exist for and the incentives within the different communities. So the rare disease community has a lot of energy from individual diseases. They're focused on finding cures and research. And so how we help that rare disease community is very different. A lot of times it's mentoring organizations to help them be more diverse, because the original parents who started that disease might not have had a diverse network of friends and families when they started their organization. So that mentorship is very different than in common diseases, where we're dealing with larger organizations and turning the ships, and there are a very different approach to, and a very different amount of resources that we have to apply to equity initiatives. And then there are inequities by populations within liver diseases. This is why equity is not a one-size-fits-all. This is not why it cannot just be, oh, we're going to put things in Spanish, to which I add, which Spanish? But we'll get to that. It's because within each liver disease, because of differences in genomics, difference in environments, difference in how diseases are triggered and progress, each liver disease has a different set of disparity issues. So we see things in pediatric liver disease. Most people don't realize that 50% of all pediatric liver disease-associated admissions occur with Black children. So many times people come up to me and say, well, at least children don't get liver disease. I'm like, oh, but they do. And African American children in this country are disproportionately affected. So that leads us, I think, would hope, to a very different approach and a very different set of partnerships in pediatrics than what we've been doing so far. We look in NAFLD and NASH, and we understand the particular disparities and propensities within our Hispanic and Latino populations. And so it's not just about making sure that our brochures are in Spanish. It's not just about making sure that we do clinical trials in Texas or California, but it's really thinking about how do we involve the Hispanic community in the shaping of the field, in the shaping of clinical research, in the questions that are asked, in the outreach to the community, in the type of information that is returned to the community so that they can be full participants as we develop in this space with an understanding of how their community is uniquely impacted so they can help save themselves. We know in hepatitis B, of course, there's disproportionate in Asian Americans, and it's been fascinating for me, frustrating, since we are a global organization, to see the understanding around hepatitis B that's in our Asian colleagues, but having to have conversations throughout the United States where it's as if hepatitis B doesn't exist, and having to fight for things like testing for hepatitis B prior to induction of chemotherapy. But we also know that 20% of new HBV infections among US adults are in gay and bisexual men. And so again, if we understand the data with that level of specificity, that will help us have campaigns and messaging and programs that are specific as well. How can we have an impact if we don't know who we're impacting and we don't know why? I'm so proud of AASLD. I know that they've launched a LGBTQ task force, and we look forward to working with them. And I think that is so important to be asking people and enlisting people in designing their own path forward rather than prescribing it for them. One other aspect of diversity, because often it is just put in terms of racial or ethnic diversity. And again, I want us to think more broadly. I want us to take down the entire wall. And that also means that we need to look at geographic disparities. Among patients with end-stage liver disease, admissions to rural hospitals is higher and has a 32% increased odds of dying, of patients have a 32% increased chance of dying compared to urban hospitals. And so how can things like Project ECHO, for example, be deployed to ensure that patients, no matter where they live, no matter the resources in their community, are still getting best practice care? We know there are not enough hepatologists to go around. We are excited to support the foundation and to make more hepatologists, absolutely. But how can we scale that care right now to people so that your zip code doesn't determine your outcome? So those are the different types of inequities and just the type of thinking that I want to encourage all of you to do as you're developing programs in this area. So we hear about stigma. People know I don't do stigma. I drive a burgundy car with Liver Lady license plates. I just don't do stigma. I don't believe in it. I have liver disease. I tell everybody, and I want people to look at me and see liver disease, because I don't think I'm who they think about when they picture a liver patient. And I want them to see me, and I want them to know that it's okay to think of me as a liver patient. I am not ashamed. There is nothing to be ashamed about. So I think one of the things that we need to do is to make sure that understanding liver disease is commonplace. It's part of the crowd. How can there be a stigma when everybody has a liver? How can you stigmatize something that everybody is at risk for? It just doesn't make sense. How can you stigmatize something that 1 in 3 people already have some form of liver disease, fatty liver or some other type? How can you stigmatize everybody? It just doesn't make sense. But it has harmed this community so much. You don't see many celebrities reaching out to partner with us. I do want to thank Bernie Williams from the Yankees for being part of our liver cancer campaign because of what his family went through. But that is so rare. We know that there are famous people who have liver disease. There are famous people whose children have liver disease. Very few of them have stepped forward. And mostly what they say is, I don't want to be associated with liver disease. Stigma harms us being able to have our Elizabeth Taylor moment, as happened in HIV/AIDS, when she reached out and talked about Rock Hudson and that her friend had HIV. And so it was okay for Hollywood and everybody to accept HIV. We need that same process of naming and claiming to get over the stigma in liver diseases so that we can move forward. I take us back to that inequity in research dollars and all sorts of funding and investment, and bring it back to this stigma. If no one wants to be associated, if it's some quiet secret, if liver disease is something that those people have and it's othered and it's siloed, then we're not going to get where we need to go, and we're not going to be able to do what we need to do for people. And so we need to enlarge our tent. We need to be very intentional about partnering with everyone, with primary care, with endocrinology, with brands. Everybody's been seeing my little Nike sneakers with GLI CEO on the corner. We need Nike. We need everybody to be involved in the effort to address liver health, because liver health is public health. The liver, as everyone in this room and watching certainly knows, that the liver is central to so many functions. And unlike, 2/3 of Americans, that we know that you only have one. And you need it to survive. And so how can we use all the levers of public health, food policy, exercise policy, environmental policy, education policy, to really ensure that there is no place where there is not a liver conversation, where there is nobody, no policymaker, no clinician, no provider of any type, no person working behind the counter at CVS who doesn't know that liver disease is a very common thing and something that applies to them. And so we launched our Liver Health is Public Health campaign, and we will not stop until liver is part of every conversation. Access. So there are many people, through these halls at these meetings who have a title of access. And what does that really mean? Often it's simply, is it covered by insurance? That's certainly a measure or method of access, but it's not meaningful, or it's not enough. So when I think about meaningful access and the work that GLI does to make sure that patients have access to the things that they need to live their fullest lives, we start with incentivizing innovation. You can't have access to something that doesn't exist. And so it is absolutely part of our charter to make sure that there is a robust research and investment ecosystem in innovation in liver diseases. It has been exciting to see, just in the 8 years of GLI's existence, to see the number of companies coming into the space, coming in from other disciplines, of seeing it worthwhile and seeing liver patients as valuable to serve. It's very important that we incentivize innovation. And I am so encouraged about the patient advocacy organizations, how we're leveling up in registries and data and the participation in that innovation, and not just as being part of trials, but being part of that research and innovation enterprise. That needs to continue, not only in the rare space, but in the common space as well. Insurance coverage is important, and there is a lot of work that we need to do to ensure that the coding, whether CPT or ICD, is appropriate for identifying all of the liver diseases that we have and the components of them, so that there could be an intelligent conversation with insurance. But there are differences in how Medicare in the US are responding to coverage across the different plans, commercial plans and employers, and Medicaid. And we need to know the differences, and we need to be able to talk with them about how those different structures can support the type of care that AASLD guidelines committees outlines, and the various care pathways that we have been working on identify as the best care for patients. That's what we need payers to support. I pull out, just one example that coverage is not enough, that 65% of people with private commercial insurance coverage remain untreated for hepatitis C. This was part of Dr. Francis Collins's presentation at the White House as he was talking with some of us, enlisting us, as we have been enlisting him, to eliminate hepatitis C. And it was so shocking to him and some of the leaders of our federal agencies who were in that room at the White House that even within programs, even within populations that had coverage, we were still not doing the job. We were still not getting cures to patients. So insurance coverage is not enough. We need to do more to have meaningful access. Awareness of disease. When we're asked, or when we ask at GLI, what can we do? What's needed? Job number one, people say, is awareness. I think that's great. We also need to ask who needs to be aware. What are they aware of? And what do we want them to do when they are aware? One of the things that we have been really diligent about is being a bridge between hepatology and other specialties, and carrying back of information about what these other types of providers need to be able to do the things that we're asking them to do for liver patients. So whether that's clarifying diagnostics in NASH, so that it's not, certainly not biopsy, and certainly not, a thousand flowers blooming, but is there clarity, as we are coming to now in the various guidelines and pathways, about how patients with fatty liver disease or NASH can be identified in a primary care or endocrinology setting. Yes, we want them to be aware, but we need to be ready for when they are aware and ask us, what do you want us to do? We need to have good answers. We need to have clear answers. That's the only way we're going to be able to scale the care that we want to be able to provide to the millions of patients with liver disease, the actually 1.5 billion patients with liver disease around the world. But we can't scale that if we can't make it simple, if we can't make it clear, if we can't tell people very succinctly what we want them to do once they've identified a liver patient. So there's work to be done in that. Part of that clarity of action, I'm very honored to be personally involved and have so many of the GLI staff involved in the development of guidelines and pathways and efforts with multiple medical societies, including serving on the AASLD NASH task force, and providing that clarity of action. And I think that's one of the things that patients bring to the table, as we have increasingly been part of AASLD committees and increasingly part of guidelines committees and other things. Patients are practical. We want solutions, and we understand the urgency of those solutions. People's lives are depending on what we do. These are not academic exercises to us. And so clarity of action, such as having a new code for hepatic encephalopathy, getting that code, not in 3 years' time, but in a few months' time, and moving forward. We have so many things that we need to do to be able to care for patients well, that we need to do them. And that's a perfect example of specific action that moves care for patients specifically forward. And access needs to fit both clinician and patient workflows. Yes, patients have a workflow too. It's called our lives. If we are trying to take care of our families and still work, and just, go to the gym, hang out, watch Netflix, chill. Whatever we want to do. We're people. And so we do not want to spend all of our time at the hospital or the doctor's offices. As lovely as some of them are, we want to live our lives. And so I heard that clinicians want to have lives too. And so the things that we suggest need to be able to fit into a clinical workflow, a hospital workflow seamlessly, efficiently, a telehealth workflow, a virtual clinic, a community clinic, a minute clinic, a nurse at my house, which is how I get my IV fluids. And again, take down the whole wall. Stop fiddling around with the boxes. We can redo this whole system, since it's not a system. We need to think about redoing it so that as we move forward, we are fitting care into people's lives. This matters even more to people who can't take time off work to go to the doctor's office. They don't get paid. They can't feed their children if they go to that appointment. They're not non-compliant. They are heroes to their families, to their communities. They often just don't take care of themselves. And so how can we make it easy for people to take care of themselves? If someone has to drive hundreds of miles, if someone has to take paid time off work, if they have to take, 2 buses, if they have to arrange childcare for their children to be able to get that test or to participate in that trial, they're likely not going to do it. And when we ask why only certain people participate in trials or access care, we have only ourselves to blame for the way that we have constructed the system. This healthcare system is working as we have designed it to work. We need to design it differently. So, policy opportunities. I could list 1,000 different, acts and regulations and things like that. But I want to leave you instead with ways of thinking as you do your own equity efforts. We are excited that we have been partnering with AASLD and others on the NASH Act and the Liver Act, the first time that there are, the names, our diseases and acts are in active legislation, bipartisan legislation in Congress. We look forward to working with whomever are new members of Congress in this next Congress, and educating them about liver disease and revitalizing the various congressional caucuses that are that do exist. There are Congresspeople who are patients. There are Congresspeople who are hepatologists. We need them to step up and be our champions even louder. But to go back to the picture about the crowd, every member of Congress has liver patients in their district. They have hospitals in their district. They have people in communities that depend on them to make sure that liver care and liver medications are available in their communities. And so we're going to leave no member of Congress behind when we start again. And I'm so excited about our growing Liver Action Network and the graduates of our Advanced Advocacy Academy, so many of which are at this meeting and in this room, with whom I've had the privilege in the pre-pandemic days of walking the hills, walking the halls of Congress with, and it is an exciting and empowering thing to be able to talk to people who can make such decisions of so much scale and impact, and see that light go on when they understand your story, and they connect it to themselves, and they connect it to their community, and they say, well, yes, I'll sign on to that. That's a very exciting thing, and we can do more of it. But I want to point out that in addition to congressional action, which sometimes can be very slow-moving and seem rather arbitrary, there's a lot that can be done within existing authority. And what I mean by that is there are existing laws and statutes and funding mechanisms already for states and local entities and different federal programs, from the VA to the Federal Bureau of Prisons, that can be shifted or realigned to be able to focus on liver diseases. In most offices of HIV and hepatitis, all the funding is in HIV. And I take nothing away from that community. I want to learn from their successes, and I partner with them. But often the funding and the resources and the staffing do not align with the prevalence of disease in their community. And so all we ask is our fair share. All we ask is that liver patients be treated in alignment with their impact on their states, on their hospital systems, on their healthcare systems, and to get the innovation that has been created so that they have meaningful access to them. But there's a lot that can be done within existing authority. And so I just want that as a point of optimism and hope for advocates to say, well, gosh, Congress is dysfunctional, we'll never get anything through. Policy is not the way. There is a way in policy, but it may not be what you think. And so that is the beauty and the joy, at least, for this Harvard Georgetown lawyer. It's a joy, it's a fun thing. I also want to point the opportunities within state legislatures. State legislatures control so much of what actually has for healthcare, whether it is state licensure of physicians and the way that we can get waivers to ensure that telehealth continues even after the someday after the pandemic, but after emergency authorizations and waivers. We've had some of our A3 advocates who have changed laws in living donation. And so there is so much that can be done at the state level. And so again, with our Liver Action Network being able to partner with ASLD physicians in their various states and communities, there's a huge opportunity to be able to affect change more quickly in Medicaid programs and in other ways on the state level. And so I'm really excited about the opportunities to work more in a coordinated fashion on the state level moving into 2023. I would also point out the opportunity at the very local level, and in fact, within hospital systems. It was a touching moment when I was asked to serve on the board of a hospital in which I got my transplant 28 years ago. Having now served 2 terms on the board of the hospital, it has been amazing the difference just a well-placed question from a board member can do. So what is our top procedure by volume? Oh, they're GI liver procedures. Oh, what are our top cancers? Oh, they're GI cancers. Oh, that was never in the board packet before. I'm really glad I asked. Everything from working with the Innovation Center to the Patient and Family Advisory Council at the hospital to changing the terminology from visitors to care partners during the pandemic, which is actually very important to patient safety and quality committee, which I now also serve. There's an incredible amount of change that can be done, and a different viewpoint on the processes and business incentives and the impact that a hospital, which is often the largest employer in a community as well, can make in terms of truly serving the community. We're in Washington, D.C. When I think about the ability that Hopkins Medicine, GW Medicine, MedStar Health can make on the health of all of DC citizens, including those in Wards 7 and 8, I think we have a larger commitment. I'm really excited to see Dr. Howell, and I know what Howard University has done to solve inequities in this city, and I think that we need more of that. I think that the hospital is an important in their hiring, in their community grants, in all the ways that their service is constructed, is an overlooked opportunity for people to serve and have impact in solving inequities. I would also say that we need, again, looking more broadly, looking at what are the levers and incentives that people have to do what they do, and how can we shift them to be more equitable and to serve patients in the way that we know they should be served and could be served. So I point to 2 things: quality measures, and I'm very honored to have worked on a paper with the National Committee of Quality Assurance, but quality measures, literally defining what is quality care. If it's not the elements of care that we've identified as most meaningful and worthwhile for patients, then what are they really measuring? So we need to make sure that quality measures are reflecting how we define quality and equitable quality for patients. I add accreditation because that was an aha moment for me just recently. I was talking to the head of a very large health system, and we were asking, what would make them change or do something, and he's like, well, accreditation. We do research in certain areas because of accreditation, and it would have just something that had never occurred to me. And so when we as advocates think about how we can affect change, how we can make healthcare serve everybody better, We need to be more creative about using all the levers of healthcare that exist. So our vision at the Global Liver Institute and how we intend to move forward in this area as a home and a hub for incubating initiatives in health equity are the following. We want to see a world where liver health advocacy organizations are governed, led, and staffed in a manner reflective of the community of the people with liver disease. We want a liver health research agenda that prioritizes identifying the root causes of and testing solutions to eliminate inequalities of access and outcomes for liver patients. This is not to take anything away from basic science, but we need more translational research. We need more research into what works in reaching people. Too often, that premise of research is denied by reviewers. I've talked to researchers who have had their grants just summarily put aside and not even reviewed because the premise of solving inequities was rejected. So we need to change the reviewers as well. I want to see a research enterprise that involves diverse patient, provider, and community perspectives in designing studies, implementing studies, and participating in them. It has been one of the most satisfying parts of my life to have built a multicultural center for clinical trial recruitment and to work with the patients in our Advanced Advocacy Academy to be able to take the points of pain that they experienced in their journey, the things that they saw that went wrong, the things that they saw that were right, but to be able to translate that lived experience into research questions. I think if we want products to be truly innovative, if we want treatments to really resonate and have high uptake by patients, and we want clinical trials that recruit fast and retain people in them, why wouldn't we design them with people from the beginning? Someone had a wonderful definition of patient-centeredness, and I was like, something is patient-centered when something changes. And I think that's right. And I think I've seen the most change in areas where patient input and increasingly diverse patient input is part of the business processes of creating clinical trials and designing protocols and recruitment plans. I think that's when it gets done right. You won't have to ask the question, well, why won't those people participate in our trials if we invited those people to help design the trials and the materials to begin with? I would like liver health care that is comprehensive and coordinated, accessible and affordable for every person at risk for and diagnosed with liver disease. Now, this one may take me more than a year to work out, but I really think that it is worth doing. How many times do you if you're a hepatologist, you sort of send patients off to an abyss and you hope that they get back to the primary care doctor or their labs or their blood work or the imaging gets one place or another. We do not have coordinated care. And patients fall through the system. Patients have a diagnosis and then years later end up in transplant or having liver cancer. We can do better. I'm very privileged to have knitted together a network of community care and academic care that serves me well, where my doctors text me and I have access to my lab work through digital portals, far too many of them. But it should not take the degree of digital fluency that I have to be able to make my charts magically talk to each other. We have to think about data that flows with the patient, care that flows with the patient, and again, things that work with the life flow and the life living of patients to be considered care, because too many people are dying unnecessarily, getting sick unnecessarily, not being able to care for their families or to continue work unnecessarily because their care was not coordinated and something fell through the cracks. I want liver health care that recognizes the impact of serious illness on parents and caregivers and provides supports. None of us who have been successful survivors to this point made it here by ourselves. We usually had a spouse or a parent or a network of friends who helped us and frankly, who may be experiencing more trauma in taking care of us than we experienced being the patients ourselves. I mean, we got to lay down. We got the good drugs. The caregivers, they didn't get anything. And so whether it's talking about palliative care that extends to caregivers, or peer support networks for caregivers, but we can't leave caregivers out when we talk about patient-centered care or solving the inequities of care. If somebody has to give up their job to be able to care for their loved one, then that is putting that whole family at risk. And so we're creating inequities with the care that we have been putting forward, in the way that we have been putting it forward, and we can do better. We would like to see liver health recognized as public health and to leverage food, environment, vaccination, and other resources to optimize community liver health. I think that's all of our vision, certainly here at this meeting, but I don't think we've expressed it as such. I think we have been focused on disease and dysfunction instead of health and wellness. That's why GLI wears the burgundy, because we want to be known for liver health, for that positive, optimum state, not the diseases that brought us here. And I think if we can start aspiring to liver health, that puts us in a much more powerful place, strength-based and asset-based place, a place that can continue to move us forward, a place that will put us on par with heart health and brain health, where we should be. So this is the vision for our GLI Center for Liver Health Equity, and I'll just give you a few examples of some of the things that we've done to make it a little more concrete. So I want to give a shout out to GLI Liver Cancer's Director Sarah Maines in the back of the room there for her awesome October is for Livers campaign. An important part of that is the expert roundtables, all of which are available on YouTube, where we convened African American experts in their own roundtable, Hispanic experts, Asian American, Pacific Islander, Native Hawaiian experts, and LGBTQA experts to tell us what are the pain points in delivering liver care, liver cancer care in their communities. What are the particular nuances that we need to do as an organization, as a field, to be able to do better? In most cases, nobody's really asked. Or everybody's sort of lumped together, and it's sort of a general conversation. I want to get really specific. And these experts have allowed us to do that. So I encourage you to look at those roundtables, and we'll certainly be circulating the ideas and marching orders, frankly, that they gave us in terms of what we need to do. I want to give so much credit to the San Diego Liver Alliance, Scott Succo, and his leadership and partnerships with Bob Gish and Rohit Lumba and others. One of our Liver Action Network members who worked with us to do a NASH education and clinical trial enrollment event at an FQHC, so primarily Hispanic population. And the goal when we asked, what would successful enrollment in a clinical trial look like? And they said, well, 2. And we enrolled 26 people that day. And 5 people were actually diagnosed with NASH. All of them were connected to care. And if we could do that in one day, in one city, Think of what we can do throughout the expanded Liver Action Network. I think the clinical research partnership potential of the liver community has not been tapped into. And we're here, and we're ready, and we're excited. And I'm excited to be able to continue to equip and train and model other community organizations to be able to do similar events and similar depth of connecting with their communities in meaningful ways. I also look forward to working with Dr. Liu, who is the Chief of Gastroenterology and Hepatology at Morehouse School of Medicine. We had mentored an IBD symposium for people of color last year and have been invited in to add liver aspects, some of which will be this December, but in full next year as part of their digestive research education and excellence aimed at minority research conference, or DREAM. So those are the starts. Those are examples. I like to be specific. I like to be tactical. I like to have clarity of action. But the opportunity is for you to tell us what's next. What can we do together? I'll just leave you with this before I open to questions and conversation. We cannot solve problems with the same kind of thinking we used when we created them. I would also add, we cannot solve problems with the same people who created them. So I think that certainly we as patients, we as members of diverse communities in all the different ways and intersections that may be represented in us, need to stand ready to work with each other, to listen to each other, to design differently, to step into the power that we have as this organization, as people who have been privileged enough to benefit from the wonderful innovation that there has been in this field, and move forward to make sure that it can benefit everyone. Thank you. Questions, comments? There are microphones there. I should be able to see questions if they're submitted online as well.
Is this live?
It is.
Hi, Donna. For anybody that doesn't know me, I'm Wayne Eskridge with Fatty Liver Foundation. And I just have to say, Donna, your vision always awes me. I'm amazed at the scope of what you think about. The thing that struck me with your talk, I think, was the comparison of the funding that is that's represented in other groups and what we deal with as the liver community. I know that all of us face this same problem of just trying to find funding, and my personal observation is that lots of people want us to do things and to make progress, but they think in little small steps. They think in small pieces, and if we're going to attack a problem this big, we have to actually have serious fundings from somewhere. And I personally failed at finding where that is.
You have not. You have done more out of a house in Idaho than most of us can aspire to.
Well, you're sweet, but I still am stuck at my home in Boise. So I'm curious if you have any thoughts on how we motivate the larger community to fund these kinds of people. We have amazing people in these organizations that have huge potential, but we're all just scrapping to make the next payroll most of the time.
I think it is broadening the conversation, and I think it is taking conversations in liver to places where they usually aren't. Half of the speaking that I do is no relation to conferences that on their face have no relation to liver. But that's just the point, that I want to make sure that people are thinking about funding liver organizations and liver research and liver advocacy. I had a conversation with John Sculley, who's former CEO of Apple, and they went through he was standing with his wife, and they went through their list of friends, and they were like, oh, so-and-so, they fund liver research. No. Well, no, they don't. And none of their philanthropist friends gave to liver research. But now he's thinking about it. So I think we just have to be persistent. I think in some ways, liver advocacy is young, and we had been fragmented and really hadn't had the visibility that we could and can. But in the 8 years of GLI, I think we have shifted that, and I think it will come. Lorinda.
Hi, Donna.
Hi.
Thank you. That was a wonderful presentation. And I just have a few comments. My name is Lorinda Gray Davis, and I am a liver transplant recipient, and I had liver disease. And this is what I found in my previous position in diversity is until companies started public reporting diversity spin with minority and women-owned companies, did corporations change? That had to change the dial.
Right.
So if they're having to change the dial in the corporate world, we have to change it in the patient world, in the medical field. And so my question is there a qualitative metric that can be put in place to publish? Because if it's being published, then people are seeing it, and more people are asking questions. So I didn't know if you had any ideas about that.
I think there can be metrics that are developed. I think it's really at the intersection of some of the work that we've done over a decade in sort of measuring patient engagement with some of the work that is coming out. I said on multiple committees, including one for Academy Health on what is value-based equitable care. So they are coming up with definitions and measures for that to be used in that context. So at the intersection of patient engagement and DEI, we can come with what does this look like for our field? But I think we need to, borrow on the expertise, yes, exactly what you're saying, from the corporate benchmarks and structures. I know certainly the FDA has been moving forward with their conversations, requirements about diversity in clinical trials. And so I agree. What gets measured, gets moved. And so we need to make sure that we are being transparent about where we are now and the progress that we're making or not. Great
Awesome.
point. Thank you.
Thank you.
Hello, Michael.
Hello. Michael Battelle from the Fatty Liver Alliance from Canada. Thank you, Donna. It was a wonderful presentation, as always. And the point I wanted to make is together, and that's your vision, too. You didn't specifically bring that out today, but together, synergistically working as one louder voice globally makes all the difference in the world. And so, GLI has worked really well that way. And I noticed through groups like the Liver Action Network, it's important because we have one message, we align throughout the year on the same topic, and it's much better than competing. And so thank you for what GLI does.
Absolutely. Well, thank you for your leadership and your partnership in Canada. I remember being several liver meetings ago being asked, well, why did you start the Global Liver Institute? I was like, well, liver disease is a global problem. As we've seen for COVID, it doesn't respect borders. And so coming together as a global community, as a global liver health community is, I think, the path of power and the path forward, because there are so many of us when we work together, and the impact on communities and families is so big that we can no longer be ignored. So thank you.
Thank you.
Karen Hoyt.
Hi, and what I want to talk about is something that can't be measured, and I think that would be that kinder and gentler space for patients to be broken and to have HE and to be mumbling. And so thanks to you for bringing us under your umbrella and helping us to develop our own skills for speaking. And I just want to say thanks to you and to the AASLD, because the way you partnered together and when you began 5 years ago to make this more patient-centric, you've given us permission to come up with our Prograph shakes and with our IBD, and you've made it allowable for us to bring our skills to the table. And so I just want to say, continue that effort. Everyone's been so generous. This is my first meeting, and everyone's so generous and so kind. So I use kinder and gentler, but I think it's about developing rapport. And no matter what your cultural background, your ethnicity, your education, or your experience in life, no matter what's going on in your environment around you, everyone longs for rapport. They want to be respected. They want to feel loved and cared for. And so we talk a lot to patients. I talk a lot to patients. How can you respect your doctor and his intelligence, his background, and his efforts, and your clinicians, and your all of your medical providers that are helping you. And then on the flip side, we're seeing the doctors looking at us and saying, how can we better understand who you are? So I think it's about love. I think it's about something that we can't measure, and I appreciate the wholeheartedness that you bring to patients and helping us, and I appreciate the ASLD and their wholeheartedness in supporting us.
Thank you, Karen, for your advocacy and for your voice and for your love to everybody that you serve and to our organization. I do want to say that this in our short time, tell a simple story. I remember the first time I was on an FDA advisory committee as the voting patient member. And I remember looking across on the other side of the red velvet rope, and I was like, it's much better to have a vote than a voice. Having a voice is great. And so I think that the work we're able to do at GLI and our Advanced Advocacy Academy of seeking out diverse advocates and training them, equipping them to be comfortable in ASLD committees, be contributing members, and is one of the things that I'm most proud of, and I think will have the most long-term impact on the field of being able to partner with diverse voices that feel welcomed, and then even if they aren't welcomed, we'll stay there anyways, and we'll get the work done. So my time is up. But I will be here for the next few days, and I thank you so much for listening.